Pino or Pino?
Pino.
Pino.
Yeah.
It would have the city
Yes.
on top if it were. Okay.
Yes, which is a separate key
A separate
on
key?
the computer.
Yeah.
So you should be all set to go. We have the recording starting from the phone. And I think we've got everybody here. We can get started.
Okay, great. Well, I'd like to welcome Dr. Esteban Pino, who's visiting from Universidad de Concepción in Chile, and has his colleagues here with him, and has been doing work in health technologies for assisted technologies, and has been here for a workshop with grant funding that they have with MIT, and we're lucky to have him come here to talk with us about the plans they have for home monitoring and health technologies for elderly care. Anyway, welcome, and we'll be happy to have the discussions with you about this topic.
Yeah, thank you. Yes, well, I prepared something about what we think could be some interventions for elderly care. But first I want to tell you a little bit about our program so everybody knows who we are. So we're a biomedical engineering undergraduate program. It belongs to the electrical engineering department at the University of Concepción in Chile. The university has about 33,000 students, the whole university. We have pretty much every area covered, so we have a medical school, now the nursing school and the medical school separated, so we have both. We have arts, yeah, literature, I don't know those things. But we cover pretty much all the areas of knowledge. It's a very big university. It's the third biggest in Chile, and it's located 500 kilometers south of Santiago, so 6-hour drive. Yeah, and we got into top 10 ranking. This was for another presentation.
Well, that's
according to QS. Yeah. Now the engineering school has, well, last year had 3,700 students, 300 in the master's program, and 50 in the doctoral program. So it's a large school. It's, engineering and medicine are the two largest in the university. And so we have a lot of kinds of engineering, but the ones in bold are the ones that belong to the electrical department. So we have electronic, telecommunication, and biomedical engineering in our department. And our colleagues all work in different areas of that. The graduate programs, we have all those masters, and our department has the Master of Science, Engineering Sciences in Electrical Engineering. I don't know how to translate that. And the PhD also is the same thing, also in Electrical Engineering. And we have quite a few biomedical engineering that went into the master and graduated. We have 6 graduate Masters of Science, 1 PhD with a biomedical background, that's what I mean. And in the undergraduate program, we have, well, that was, I think we are up to 140 graduate students. And we started in 2005, so it's kind of new. We have like 4, because engineering in Chile lasts 6 years, so it's longer. So we have like 4 promotions. Yeah, I think, well, we have a big discussion about that. The education in Chile. Basically, they do like a first year of math and chemistry and physics to level up what they learn in the high school.
Okay.
So that they lose a year there, and then we're trying now to reduce, but we're reducing from 6 years to 5.5, so it's pretty much the same thing. But we're moving in the right direction. Okay, so and our current project with funding, I wanted to put here, in different areas. The core faculty is 4 professors, and each one has its own line of research. So first, Pamela with biomedical imaging has a grant on the study of brain connectivity using diffusion MRI, and that's the picture we just showed you of the connectome, in the brain. Then I mainly work on unobtrusive sensing and signal processing. So I have this advanced signal processing for unobtrusive sensing. It's a big name for just unobtrusive sensing. But we try to test different algorithms and detect events and all from data acquired from unobtrusive sensing. We have a view project, which is something you develop during your stay at the university. You want to try to make it a commercial product. And that's where we develop this sheet for sleep studies that I will show you, and it's supposed to try to go to commercialization and be useful. And this MISTI project with MIT, and it's our second grant in the MISTI. And then Pablo here works on neurostimulation, and his grant is omnidirectional wireless power transfer for implants. So you do the power transfer without puncturing the skin, wirelessly. And his other big project is a drop foot device to help walking, improve mobility. And I will show you also. And then the 4th professor works more in the medical informatics field, but mainly on natural language processing. So she has right now a project called adaptive selection of training set based on active learning. So she wants to pick up which words are key to train on something. I don't know much about that, but that's the main idea. So that's like the 4 main areas that we are developing in biomedical engineering at our university. So the idea of this, of the thing that I will present, is that just this year, the government put out this big grant for research in priority areas, and they defined what is priority. And there were 4 areas this year, and one of them was aging processes and factors associated to adult health and well-being. So the focus has always been more in biology and medicine and aging processes with the cells and everything. But we got invited. It's not our project. We didn't lead the project, but we got invited to propose technological interventions to help the care of the elderly. And that's how we started thinking about how can we apply our development to elderly care. So that's what I'm going to talk to you about a little bit. So it's $1.4 million per year, per 5 years. That's a lot of money for us. And you can extend it if you do well for another 5 years. And we're waiting for the results. We already applied and was with an interview and everything. That's done. Now we have to wait. But anyway, if it doesn't work, it's a very interesting area, and we started making contact with geriatrics. How do you say that?
Geriatrics?
Yeah. So we think we're going to keep working on this. And we also have a couple of undergraduate projects that are in this area and everything. So we already started working a little bit. So the way we thought about this is that we were looking for gerontechnology applications. It's a word that I didn't know 6 months ago. And we try to focus on this population, independent population living at home, for instance, by themselves, fragile populations, which are about to, if anything happens to them, they can become a dependent population and they need care. So it's a particular kind of population. And then the dependent population, bedridden or wheelchair, or that they need someone to take care of them. And also wanted to focus on the caregivers, and that they can be professionals or the family, because that's something that happens in Chile. Families take care of their elderly or the sick. And the idea is to contribute, I mean, this project would contribute at 3 different levels, like public policies for the country. Our health system is based on like smaller areas. It's not a city, but it's not a whole region, so there are many small compartments, I don't know. So try to improve the care in the primary hospitals and up to the tertiary hospitals with more complexity. And also to contribute to the individuals, so some device to help you do better your daily activities. So those 3 levels. So this is kind of everything. You can't read much, but the idea was here psychosocial aspects and mainly depression. This is with psychologists and psychiatrists. This is mostly what they thought about is like I don't know, surveys or something on tablets, on phones, whatever, to detect depression or social issues. Then here we have cognitive aspects. So we developed a program for cognitive training for children, but we wanted to apply it to elderly. And here is the daily activities, so functional support system. We have healthy living, and here we put gerontechnology. We wanted to do like assistance and or data gathering, and then interventions. Those are the 2 main aspects. And I will show you all those pictures are things that we have done. So the main lines would be psychosocial interventions for depression screening, and it's mostly based on surveys. So I won't talk about that because I don't have much to show. Then cognitive interventions to study brain plasticity in the elderly, and evaluation or training for them. And then the main topic would be functional support system, and we have unobtrusive sensing and healthy living, and then support for frail and dependent populations. So the first project we did with Pamela is this interactive system for infant stimulation. It was a project with between us and the Catholic University, one of the second biggest in Santiago. And so it was based on a touch screen, and it was meant for children 18 months old, so very small. And it would show you different pictures with words. I have an example, and he has to touch. And yeah, then the other option was to use eye tracking. It was meant for smaller babies from 6 to 10 months. And you would put some stimuli with numbers, I mean, a different number of small points, and they move, and we wanted to see if the child would look the correct, I mean, the one with more, I don't know the details of the experience because it's more psychology, but we wanted to do that. We programmed it, but it didn't work because the eye tracking that we were using needs calibration first, and for that you have to cooperate. You have to look at the one corner, then at the other corner, and those those subjects didn't.
They were cooperative
Yeah,
subjects.
so that didn't work actually, but the idea was good. And then sustained attention. We tried to do a little bit of that. First we tried to do it with eye tracking, but we had that problem. The second approach was to show something in the screen, and the child would press it, and he had to keep pressing for a certain amount of time, and you could train it. And so if you train sustained attention, that's a very good proxy for then doing good at school and everything. So what we actually do and implement and test was the first one, the touch screen. So it's something like this. We present 3 squares, and the middle one would always, a teacher would come up, very friendly and child-oriented, and she would present what's on the left and what's on the right. Sometimes it would be a new word, an invented word that doesn't exist. Sometimes an infrequent word, and sometimes a frequent word, something that the child should know. And then he would cover her eyes and say, "Where is the pig?" I don't know. And the child will have to just touch on the picture. And we tested it in 2 different child care. It's a government program to care for child that are either abandoned or that are at the government care pending trials with their mothers or whatever, and fathers, of course. So it's the idea was to do more things with them, with interactive games, because the mother was absent. We got good results. Some kids had like learning curves. I don't have those results here. I tried to look for them, but I didn't find them. You can see that they learn new words, but others don't. So that's variability. But what was interesting is the fact that they answered. I mean, they learned how to play the game, and they started playing it, and that's a clear graph that shows that all the child got involved in the game, and it was interactive, and they responded when they had to respond. So that's something that
At 18 months?
Yeah.
That's impressive.
Yeah. Well, they started at 18 and ended up with 22, I think.
Okay.
Yeah, but it was a good result. So it was we were very happy about that. So we think the other tool that we made, I think it was also, like you said, meant for autism. The child had to answer if the eyes were looking at the object that was. But this is like a side project, and I know that they did it, but I don't have more details. That's for my colleague. So, and that's also, I think that was also implemented in a tablet or something like that. The previous one, the SIEL, was implemented in a big touch screen computer, but then they got a tablet version. So what we thought is that we can use this technology to assess cognitive state and try to figure out if there was a decline, and with training try to slow down this decline. That's mainly what we were thinking of, how to use this in the elderly population. And and that with combined with somehow monitoring activities of daily living, try to detect mental frailty and social problems that they don't talk to other people, or they forgot to eat some days or whatever. So that's our plan. Then in obtrusive sensing and healthy living, and this is more my area, so I'll explain a little more here than in the rest of the project. We have sleep studies, unobtrusive heart rate and respiration monitoring, and also some activity monitoring. So, sleep is very important. We all know that for learning, memory processing, recover brain excitability, etc. So the problem is when we developed this, we were thinking about sleep disease, and the main sleep disease is sleep apnea hypopnea syndrome, which is 4.6% the prevalence in Chile, and it's very similar to the States. I just came up with between 3 and 7. I don't know, but it's yeah, it's very similar, and it causes brain damage, increased insulin resistance, somnolence, decrease of reaction time, traffic accidents, loss of coordination, cardiovascular, a lot of problems. So we wanted to try to detect this and then do some intervention and then also a follow-up. The problem was that currently the two main ways to address this is by questionnaires. How did you sleep last night? Do you feel tired now? And those are the main questionnaires, but those are subjective indexes. And the objective index is through polysomnography, which means you have to go to a hospital and get all wired up and not sleep in your own bed. And you can do, like you said, you can do that every day. So it's uncomfortable, it's expensive, and requires hospitalization. So what we propose is like a sheet with force resistive sensors. So the resistance changes when you press them. So it's a sheet of 8 by 3 sensors, and you would put it under the first sheet in the bed, and then you just go and lay down and sleep. You don't have to do anything. You don't have to wire anything. And with those sensors, we can detect the respiratory signal and the body movements. I mean, the respiratory signal, I mean the fluctuations in the thorax when you are breathing. And body movements, I mean when you turn around or you get up or off the bed. So the parameters that we compute is time in bed, periods out of bed, and number of sleep intervals longer than 20 minutes, which those are supposed to be REM states, which is the deep, you want to have like 5 or 6 of them per night to have a full night's sleep. The percentage of time in sleep intervals smaller than 20 minutes, which is kind of the opposite of the other one. So if you sleep all night in short intervals, you don't rest because you're waking up. That's bad. And the apnea hypopnea index, which is when you do apnea. And we try to devise some sleep quality index from all those parameters. So this is the system. It's just the sensors here, and then we have conduct thread that we sew into the sheet, and that goes. Well, here it doesn't show, but it turns into this cable, which goes into this box, and that records the data. And you would next morning you take the memory out and read it, or you can do wireless transmission. So the pressure sensor, analog multiplexing, transducer, analog to digital conversion, and then wirelessly or to the data logger, or both at the same time. So that's the hardware, and this is the kind of signals that we get. So it's 24 different signals, and we can detect when he got out of the bed, because all the signals will go to 0. We can also detect body movements or changing positions, because the signals always they go all the way from down to very high slope. And in between movements, you can see the respiration right here. Well, it doesn't show. The resolution isn't very good. I have another picture. Yeah. Between movements, you can see the breathing rate here. Okay? So you have to just pick the best one, and then you can compute the breathing rate. So we started looking at the different parameters, and what we propose is like a scoring system, like the when you get to the hospital to see if you respond to instructions. There's a score to see if you have brain damage or something. Well, something similar.
Basic scoring, yeah.
Yeah. So we started scoring. We put the higher the score, the better your sleep. So in this case, time in bed, it's like a measure of how committed you are to sleeping. So between 7 and 9 hours is the best, and that gets 3 points. And that's very easy, because you can see when it started and when it ended, and that's it.
So what's the color code on that graph?
Nothing. There's different sensors. If you see, first we have the red one, and then it changes position, and now the best is the green one, because the red is down here, so it probably turned over, and that sensor.
So it's related to the individual sensors.
Yeah. So the colors don't mean anything particular. Then period out of bed during the night. So we can see that there's no sensor pressed here. So this is a period out of bed. So we did a score for that also. So if you have no periods out of bed, that's the best score. If you get up one time, 2 points. And if you get out 2 or more times, it's 1 point. Then the body movement. So here the main idea is we wanted to check how many times you had more than 20 minutes without interruption. And we're assuming that corresponds to a deep sleep state. So we count, we detect the edges here, which means a change in position, and then we figure out how long he stays in the same position. So if he has more than 4 of those deep sleep states, that's good. And also we computed what's the percentage of the time in short interval. So because usually the sleep cycle is like 90 minutes, and 30 minutes are in REM sleep state. So that's 1/3. So that's why we came up with 66.6% of the time. So we have less than that in short interval, that's okay. If you have more than that, then that's bad. So that's why we have 3 here and 1. Then the apnea detection, we did that looking at the variability of the signals. When it's flatter, it's because it's an apnea event. And also, if you have from 0 to 5 apnea events per hour, that's normal also. So we have this score here. Okay, here. So
I thought people weren't supposed to have any.
no,
apnea
there's
events.
one.
Apnea.
We work with neurologists.
Uh-huh.
And then we did also research in papers, of course. Yeah, it's normal that you have some apnea. I mean, if you have
5 an hour.
yeah,
Okay.
that sounds like a lot, but
Yeah.
it's
Okay.
not such a big deal.
Interesting. How are you defining apnea again?
I think it's 10 seconds.
Oh, 10
without,
seconds, okay.
No, sorry.
No.
That's too much, right?
Yeah, that's.
No, it's
That's okay.
there's a number.
Yeah. Look it up.
Okay, so wrapping it up, the sleep quality index is just the sum of all these